Hello, welcome to this program on A2A receptor antagonists as potential adjuvant therapies for levodopa optimization in Parkinson's disease. My name is Werner Poewe. I'm an emeritus professor of neurology and a past chair of the Department of Neurology at Innsbruck Medical University, and I have two eminent PD experts with me here on this round table, and these are Professor Angelo Antonini. He's professor of neurology at the Department of Neurosciences at Padova University in Padova in Italy. Hello, Angelo.
Hello everyone.
And I have Per Odin, who is professor of neurology and head of neurology at Lund University in Sweden. Hello, Per.
Hi.
Our learning objectives, as we discuss among ourselves today, are, of course, to review with you the different adjuvant medications that we use in patients with Parkinson's disease, and also how that affects levodopa dosing when we do so. But we are going to focus on a new mode of action class of drugs that may be helpful in slightly advanced stages of Parkinson's disease, and these are related to the role of adenosine as a transmitter and adenosine receptors in signaling in the basal ganglia. That will be a focus of our program today. And as we go into this, I'd like to remind all of you about the basics, so to speak, of Parkinson's in trying to understand the potential role of A2A receptors and drugs that modulate the activity at these receptors. One has to remember, of course, that Parkinson's disease is a striatal dopamine depletion disorder, that the loss of dopamine through nigral cell death, the loss of dopamine in the putamen that results from that is at the basis of the cardinal motor symptoms of Parkinson's disease, like akinesia, rigidity, rest, tremor, and of course that all the treatments we use that try to replenish striatal dopamine, they are symptomatic therapies. They're not able to reduce the progression of the disease or slow it, unfortunately, but they are very powerful agents. And because there's always room for improvement in treatment of any kind of symptom of Parkinson's disease, there's been a constant and ongoing activity to try and identify drugs with new modes of action and to meet the problems that we have with our current treatments. Per, I know that you have a special interest in also advanced Parkinson's disease, the stages that are beyond the very early ones where we have very successful responses to levodopa and other dopaminergic drugs. Would you maybe tell us a little bit about issues like motor fluctuations and problems that come from there, Per?
Yes, Werner, as you told, the main problem in Parkinson is of course the dopaminergic deficits, and the treatments that we have today, they focus on that and try to compensate that, and thereby to reduce off time and improve motor and non-motor symptoms remaining in off and also in on to some degree, and at the same time to avoid treatment-related side effects. How we choose to start the treatment and use our present drugs depend on a large number of factors. It depends on the age of the patient, how strong symptoms of motor and non-motor type that he or she has. But we also, of course, consider the risks for development of side effects and complications, long and short term. So the drugs that we have presently, levodopa first remains the gold standard. Of course, it's the drug with the strongest symptomatic effect on motor symptoms, and but it has, of course, as we all know, the drawback that with peroral use we will long-term come into motor fluctuations and dyskinesias in very many patients. Until some years ago, it was therefore popular to wait a bit with L-Dopa and start with other dopaminergic drugs, especially in younger patients, to postpone these problems of fluctuations and dyskinesias. But the studies that we have around this are not so convincing concerning that we could really postpone in that way. So I think we are moving back to using L-Dopa already early in many of our patients, but to be careful with the dosing and use rather low doses. The other big group of drugs that we have, another one is the MAOB inhibitors, of course. There we have rasagiline, seleglin, safinamide. They, at least rasagiline and seleglin, can be used as monotherapy. Then they have relatively weak effects, but often nice. They can also be used in combination with L-Dopa, also safinamide, and then we get a bit stronger effect, and this helps for off symptomatology and wearing off fluctuations. Another group is the dopamine agonists, and there we have mainly today the non-ergot agonists, including pramipexole, ropinirole, rotigotine, and they can also be used as monotherapy early, but they have a longer effect than L-Dopa, but a weaker effect than L-Dopa. So in case we start with the dopamine agonists, we will in most cases have to add L-Dopa later on. Dopamine agonists can also be added to L-Dopa therapy later in the disease process, and then they will also help against off fluctuations and so on. Finally, we have the COMT inhibitors, entacapone, tolcapone, opicapone. They are always used together with L-Dopa. They prolong and make the effect of L-Dopa a bit stronger. So we have three groups of drugs that we can add to L-Dopa treatment and when we do that, we get an improvement of the off symptomatology, but with the risk, if we don't reduce L-Dopa, that we can get dyskinesias. So where are the problems with these depressant drugs then? Well, of course, we have side effects. We have from L-Dopa, the typical early side effect is probably nausea. Then we have orthostatic hypotension. In the long run, as we have said, we can get dyskinesias. We can also get hallucinations, psychosis. Many of these are dose related. For example, the hypotension, the dyskinesias, the hallucinosis often gets more pronounced with higher dose. Among the dopamine agonists, we find partly similar side effects. We have orthostatic hypotension. Again, we have nausea. We have dyskinesias to a less degree than with L-Dopa, but still we have psychosis, and we have more typical for dopamine agonists maybe excessive daytime sleepiness and impulse control disorders. Again, some of these are dose related, the hypertension, the psychosis, the sleepiness, and maybe to some degree also the impulse control disorders. The MAOB inhibitors, they are rather well tolerated mostly. They can, however, give some disturbance of sleep, especially seleglin, and this might again be dose related. Nausea, hallucinations, and impulse control disorders can occur or get stronger also with MAOB inhibitors, but that is rather rare. So we have a number of side effects of the present drugs that can, of course, influence the total effect and the quality of life for the patients that use these drugs.
Yes, Per, thank you. I think it's important that you highlighted the issues around tolerability and side effects of dopaminergic approaches to treatment, and particularly that, of course, dose is an important factor. So anything that we can do to reduce dose-related side effects will be welcome. And the question is, could drugs that enhance dopaminergic agents' efficacy through other mechanisms, could they be of value? And that brings me to our central topic of A2A receptors and antagonists, and those receptors as a potential drug class for Parkinson's disease on treatment with levodopa and other dopaminergic drugs. In order to understand the potential of these agents, I'd like to make the audience aware of how we believe that adenosine and adenosine receptors modulate the activity in the motor pathways of the basal ganglia that are affected in Parkinson's disease. And looking at the cartoon on the left-hand side under A, we see a schematic representation of how the two major pathways that project from the striatum to the output nuclei of the striatum, the globus pallidus, external and internal segment, how they are modulated by two GABAergic pathways we call the direct pathway, because it is a direct connection between the striatum and the internal segment of the pallidum, versus the other we call indirect, because it has a two-step approach. It goes to the external segment before signaling continues with a second GABAergic neuron, again to target the internal segment, which is the central output relay station of the basal ganglia. And dopamine has differential effects on those that result in facilitation of movement in normal mobility. And the loss of dopamine, as we have it present in Parkinson's disease, results in an imbalance between these two pathways. There is underactivity of the direct pathway, meaning there is less GABAergic inhibition of the internal pallidal segment, and in consequence there is inhibition of movement at the cortical level through thalamic relay neurons that become affected. And we have the opposite, an overactivity in the indirect pathway. And that has the same result of inhibiting mobility and movement as has underactivity of the direct pathway. And now adenosine receptors come into play because they are differentially expressed on this indirect pathway, which is overactive in Parkinson's disease. And that brought forward the idea, if one were able to inhibit, to antagonize these receptors, one could enhance the activity of dopamine replacement, which also downregulates this overactivity towards improvement of motor symptoms of Parkinson's disease by blocking these receptors. And that's shown on the right-hand half of the slide, how A2A receptor antagonism helps levodopa and dopaminergic agents to block the overactivity of the indirect pathway and thus be an enhancer of their efficacy. That's the basic idea behind it, but theories are nice, experimental evidence is nice. We need to, of course, be sure that this really works. And Angelo, I do know that you've been involved, and we've even written a small article together reviewing studies with A2A antagonists in Parkinson's. Maybe you could update us a little bit of what we know, what we can be sure of from experimental and clinical trials with these agents.
Thank you, Werner. I think we have had in the last decade a lot of results coming out of clinical studies, but also from preclinical studies on A2A receptor antagonists, demonstrating that they are indeed a viable strategy to treat Parkinson patients. As you mentioned, there is a potential advantage that the use of this medications would act exclusively on the indirect pathway with no effect on the direct pathway, which has been potentially linked to some of the adverse events that we see with dopaminergic therapy, including the cognitive and behavioral changes that might be triggered by the use of a much broader spectrum dopamine agonists. And also the possibility that by modulating only the brain dopamine D2 receptor, these drugs would not trigger peripheral adverse events, which are quite bothersome to patients, like orthostatic hypotension, or at least would not aggravate that, since this is one of the features of Parkinson's disease in some cases. Overall, if you look at the preclinical studies, I think we have a number of results which are not only for the most advanced A2A antagonist is tretefilin, but also for tozadenant and preladinant, where you see that there is a improvement in motor function, possibly in animal models. Also, the early use of istradefilin demonstrated the possibility to prevent the onset of motor complications, particularly dyskinesias. And for another A2A receptor antagonist, preladinant, also the possibility to minimize dyskinesias in animal models if they were already present in combination with levodopa. So if we look at the results from clinical trials more in details obtained in humans in a number of studies, I think they can be relatively easily summarized. I think the best and most consistent result is the reduction of off time. The reduction of off time has been obtained with all three so far tested A2A receptor antagonists. There is not only reduction of off time, but for istradefilin, there was some motor improvement also obtained when the drug was used in combination with levodopa, indicating that it can actually boost the effect of levodopa and exogenous dopamine, so which is potentially beneficial to people with Parkinson. Another important effect which I would like to highlight with istradefilin is the fact that in those patients who were randomized to clinical studies who had dyskinesias, there was no worsening of these dyskinesias. And this is a kind of unique condition. All other adjunct medications to levodopa have generally the effect to increase dyskinesias. This is not only for the dopamine agonists, but also for the monoamine oxidase B inhibitors and the CNT inhibitors. They all had the tendency towards dyskinesia. This was not observed with istradefilin. And for instance, with tozadenant and preladinant, there was even some improvement, amelioration in dyskinesia severity in patients who are randomized to those two drugs. If we have to look at the effect sizes, and the table already displays quite clearly that you not only see an effect on extension of on time, a reduction of off time, which is quite consistent with all so far tested adenosine A2A antagonists. But there is also a modest improvement, but in some cases significant, in UPDRS3, which suggests that there is better motor control during the on phase at a given amount of levodopa administered. Not all three A2A antagonists are at the same level of development. Luckily, so far, istradefilin has been introduced to the market first in Japan, and then next to the United States, which is, I think, a big step forward in increasing the available treatment options for our Parkinson patients. The other two A2A antagonists have had a bit of a mixed fortune, and their development has been so far not continued, but the introduction of istradefilin to the clinical use offers the opportunity for additional research in this field and in this class of drugs.
And if I may add, Angelo, if I may add to these two others, they're the lessons as one can learn often in clinical trials. Tozadenant failed because of toxicity, which is always a risk with any new drugs, and there were these agranulocytosis cases. And preladinant was an interesting example where the trials in phase 3 failed although everything from phase 2 was very, very positive and very consistent with it, istradefylline, but the trial comparator also failed in the study program. So probably it's not, we probably have more evidence for the class that to work than has come out of the total number of trials. Wouldn't you agree?
I think the studies were conducted in different patient populations. Maybe not everyone was ideally selected. And I also believe that we have not fully exploited the potential advantages of using A2A receptor antagonists in Parkinson patients. And the experience has been with this drug class, the difficulty in capturing, in some cases, the reduction in off time and also the relationship with the amount of dopaminergic therapy, concomitant dopaminergic therapy administered, which may actually dilute the effect of the A2A receptor antagonists. I think some of the studies had focused on early use monotherapy. At this stage, I think we cannot encourage the use of A2A receptor antagonists as monotherapy, even if there are animal model results suggesting that they could boost dopamine effect. I think they are not supposed to replace levodopa, but rather they are a viable option to enhance levodopa efficacy by increasing dopaminergic transmission in the indirect pathway. The potential is to look at specific class of patients, and particularly in delaying the onset of dyskinesias, which would suggest that maybe this drug class should be the first to be introduced as soon as patients are started on levodopa. And maybe for the future studies, it would be interesting to look at delay in onset of motor complications.
True.
But we do need more data. What do you think on this?
I think that's something that is certainly worth exploring in future. Would using these kinds of different mode of action approaches alongside dopaminergic replacement in the beginning alter the long-term risk for some of these complications? Important aspect and pair, where do you, in your view and experience, where do these agents fit our portfolio of dopaminergic drugs and treatment approaches to PD? Could you give us your take on that?
Yes, Werner. Well, I think that the evidence so far speaks for that these drugs have a comparable effect to other adjuvant drugs that can be combined with L-Dopa. There is not evidence really that they have more effect, but also not less. So question is, when shall they be used? Where are the advantages? One is potentially, like Angelo said, that if they have little tendency to development of dyskinesias when they are combined with L-Dopa, this might become an option that instead of raising the dose of L-Dopa and other dopaminergic treatments, one could add A2A antagonists. But we do need, like Angelo said, we do need more clinical studies illustrating this. Another interesting difference to other adjuvants concern the side effects, of course, like was mentioned that the orthostatic hypotension with these A2A antagonists seems not to get worse if it's present. And we know that orthostatic hypotension is something very common among our patients. Up to half of all the patients have this as a result of the disease, but often also increased by the dopaminergic treatment. So in such patients that have tendency to orthostatic hypotension, this option to take A2A antagonist instead of one of the other adjuvants or instead of raising the L-Dopa dose can be very interesting. And this concerns also sedation, and in that way it can also be relevant for for falls in elderly people and so on. So the side effect profile and the differences in side effect profile to other Parkinson drugs is very interesting and might influence how we will use it. Of course, maybe the most interesting part is this with dyskinesias. We know that our dopaminergic treatments, they have a relatively strong tendency to develop dyskinesias with time. And if the evidence here is true that the A2A antagonists have little tendency to dyskinesia development, also in combination with L-Dopa, then this will be a very strong thing. But as we said, we need more studies here. And another area which is relatively unexplored so far are the non-motor symptoms. But there are preliminary data indicating that there can be interesting non-motor effects also of the A2A antagonists, maybe concerning cognition, maybe concerning depression, anxiety, and so on. And it will be very interesting to see further studies focusing on this side.
Certainly. And since you're mentioning dyskinesias again, which Angelo already touched upon, Angelo, this is something that has been in the focus of your interest, how to modify the risk for dyskinesia and reduce them. So would you say this is a new hope we have here with A2A antagonists as adjuncts?
I think as we have discussed so far, and Per, I think, nicely highlighted this, we have already some evidence from animal models that the action of this drug class, which we could translate into clinical practice once we have istradefylline in the market, would be really to act on the D2 receptors, minimizing stimulation of the D1 receptors, which potentially, as already shown in animal models, could lead to reduce dyskinesias or to less severe dyskinesias once this is administered in animals. In patients, the data derived particularly from the studies from istradefylline and also from tozadenant, both suggesting that you do not see an increase. So this is something which is definitely worth exploring, potentially using these drugs early, before patients manifest the involuntary movements, to see if we can provide a dopaminergic stimulation with a better balance between indirect and direct pathway without excessively facilitating movement through the direct pathway and possibly modifying brain plasticity and reducing the expression of movement patterns, which would be very difficult to get rid of once they are already present.
Well, thank you, Angelo, for highlighting this again. And I think we're at the end of our discussion and ready to summarize. I think we've seen and been able to show that A2A antagonism is a viable approach, a rational approach to adjunct levodopa and dopaminergic therapies to optimize their efficacy in advanced Parkinson's disease or Parkinson's disease with motor complications due to levodopa. It's not a drug class that is an alternative to levodopa, but it's clearly a valuable adjunct. Per, you've highlighted side effects and mentioned the dose relationship regarding orthostatic hypotension as a consequence of drug treatment, and that is part of the disease but can be made worse by drugs, and reducing the dose through adjuncts may be helpful. And we haven't been able to go into the non-motor symptoms very much for lack of evidence, but it's another interesting area of potential use that we would have to explore in future studies. So I would really like to thank both Angelo and Per for joining me in this round table, and particularly I would like to thank you as the audience for having listened to us. Thank you very much.
Thank you all.